Hi, I'm Doug Dormer, and this is the Business of Health Informatics B641 in the master's program in the Department of Biomedical Engineering and Informatics at Indiana University, Indianapolis. This is Module 3, Lesson 1, when I want to present an introduction to healthcare and specifically health IT problem analysis and solution development, and a bunch of other stuff. In the agenda for today, we're going to look at three things in the news in this first lesson. Then I want to discuss the wonderful work my students did when I asked them to review and comment on a wonderful document, a mid-year review of health information technology trends and investments, published by the group Healthcare Growth Partners. They did a great job. Then we'll really dive into healthcare problem analysis and solution development, particularly as it relates to health information technology and health informatics. And then finally, I want to introduce you to a notion that I just call the value equation. How do you identify and assign a financial value to things that are just not easily valued from a financial perspective? In the news, this is a bit of a cautionary note. Americans face biggest increase in health insurance costs in 15 years. It caught my attention. I thought I have to see what they have to add. It was in the Financial Times. Well, after I got through to it, which took a bit of time because it was behind a paywall and our university library doesn't subscribe to the Financial Times, what I learned is that it was a very superficial, high-level discussion of costs of healthcare, and really nothing we don't find from other sources that we would generally look to. And so it serves to remind me to counsel my students. We're not just looking for anything that's out there that's related to health IT or healthcare. Really think of this as what we do in healthcare practice generally, which is to say we follow evidence-based practice, or we try to. This is evidence-based business practice, evidence-based healthcare business practice. And so rather than looking at sources like this, pay attention to them, see what they have to say, but don't linger on them. Even other sources that summarize information can provide considerable value. But sources that are just a summary of the shallow information don't give us much real additional value. So instead, something came out in July to make that point from the Medicare Payment Advisory Commission, a group that produces really good information about healthcare spending costs and trends and patterns, particularly as they relate to the Medicare program. So this was the most recent report that came out in July of 2025. The first thing I note is that Medicare was the largest single purchaser of personal health care in the U.S. in the most recent year, 2023. So as you can see here, Medicare accounted for 23% of the $4.1 trillion. Medicaid came in at 19%. CHIP, the Children's Health Insurance Program, the Department of Defense, now sometimes called the Department of War, and the Veterans Administration came in at 4%. Other third parties include the Substance Abuse and Mental Health Services Administration, the Indian Health Services, and some other things. So the other third parties is kind of a blend between private and public funding, compared to private health insurance of 32%. The significance of this is that from a financial point of view, we tend to think of the United States as primarily a private insurance sector-driven health system. But as we can see here, the federal government or state governments, combining Medicare, Medicaid, CHIP, DOD, and the VA, and a bit of the third party, really are at about 50% of the total cost compared to 32% for private insurance. That's a significant data point, but it's not the end of the story. Let's take a look at what happens when you compare payer type to administrator type. In this graph on the right, we can see Medicare is about half traditional Medicare. You submit a bill, the bill gets paid, subject to rules and various constraints, but it's a fairly straightforward reimbursement model. The other 12%, the other half or so of that 23 total, is Medicare Advantage. Essentially, the federal government gives Medicare funds to insurance companies who administer their insurance policies much as they would under private health insurance. Similarly, for Medicaid, which accounts for 19% of the payer types, 14% is under Medicaid managed care organizations, while only 5% is straight pass-through, analogous or closer to the traditional Medicare. So that gives us an insight, but it's a bit confusing. So let's shift that around a little bit. And now we can see Medicare 12% direct, Medicaid 5%, other payers perhaps 9%, most of which is government covered by the government. CHIP DOD at 4%. So add that up and you get 12 plus 4 is 16, plus 5 is 21, plus 9. We're at around 30%, maybe a little bit less, because that other payers is part commercial and only part government related. Now compare that to the other side. Add to it the private health insurance payments of 32, Medicare Advantage at 12, which is 44, and 14% for Medicare managed care organizations, and we're at about 58%. And those numbers from Medicare Advantage and Medicaid managed care organizations are increasing. So we can see from this that while only about 30% is administered by federal or state governments, approaching 60% is administered by private insurers. That's a hugely important data point as we consider the role of health information technology and who the stakeholders are that we will need to address. Now, also from that same report, another interesting graph came up. It looks at Medicare's share of national spending on personal health care by type of service, again for 2023. So we can see here that the two big ones that stand out are home health and nursing care facilities and continuing care retirement communities. So this is interesting. We can see that 70%, 35% for Medicare and 35% for Medicaid, of home health care costs are paid by the government. Similarly, when we look at nursing care facilities, we can see that 51% is paid by the government, including 21% by Medicaid and 30% by Medicare. So it's an important data point. Depending on what our role is with respect to health information technology, what kind of provider we're dealing with, what kind of services delivery we're looking at, that determines both what kind of payer we need to be addressing, as well as what kind of administrator we will need to respond to. Now, here's an interesting piece. On a per enrollee basis, let's look at the cumulative growth in spending since 2008 to 2022. Again, this is the most recent I could find, and this comes from the Peterson KFF, Kaiser Family Foundation Health System Tracker, a wonderful resource that's continuously updated. Now, as you can see here, when we are looking at cumulative growth in per enrolled person spending, Medicaid comes in at about 22%, Medicare comes in at about twice that, at about 42%, and private insurance comes in over 60% increase, cumulative increase since 2008, or between 2008 and 2022. I think that's a pretty significant data point. We tend to think that the government is less efficient. We tend to think that private insurance and private organizations can operate more effectively. Certainly from a cost per individual, this raises question. Does that mean that private insurance pays for services more easily, more readily? We don't know yet from this. Does this mean that private insurance has higher overhead? We don't know this. So we have some interesting questions, and for now I'll leave it as a data point to keep in mind. Now this is an interesting trend. This comes from the New York Times on September 5th of 2023. So it's 2 years old. I couldn't find an updated version of exactly this. And what it shows is that between 2010 and 2023, the average cost of Medicare has tended to flatten out, the average cost per individual. And it notes a gap when you compare what the actual costs were compared to what the projections were. And we don't know the date of the projections, but they were presumed to be the case before 2010, that this would continue to increase, roughly following the original curve that it had been on, so that by 2023 we might expect to see an average of $22,000 per individual. Now, this was published in September of 2023 and shows $12,500 essentially as the average cost per individual. I thought, well, how can you know in September what the average cost for a year is? So I looked it up to find out what it actually turned out to be. And it turned out, according to the Kaiser Family Foundation, a wonderful source, that as of this year, when we look back on 2023, the average cost was $15,727, higher than they estimated, but still well within that area under the curve. I think that's a significant indicator showing that the cost of Medicare has not increased as fast either as Medicaid, as the other sources, particularly private insurance, or as fast as it was projected. Now, we could go down a rabbit hole and talk about funding for Medicare, but we're going to skip that and save that for another day as well. Now, I wondered why. Can we identify why these patterns are happening? And I found a very interesting graph. Now, this one goes back even further. It looks at the period from 2009 to 2019 and identified three major trends that affected how you project Medicare costs. Not only project, but also the reality of those costs. And as it shows here, for each of those years, economic changes was a significant component, but the least of more important of the three, perhaps. The second area were the technical changes. Those perhaps had a significant impact as well. Got to tell you, at this point when I looked at this, I didn't know what technical changes meant, so we'll look at that and figure that out together in just a moment. And then, of course, we had some significant legislation, the impact of Obamacare, which for some certainly increased the cost of health insurance, but for others and overall, it contributed to lower costs of overall health insurance over time. So I asked the question, particularly what are the changes first and what are the technical changes second? Well, the economic and legislative changes, the legislative change, the big one is, of course, the Affordable Care Act, also known as Obamacare, provided health insurance for 31 million people who previously did not have insurance. The evidence shows that having insurance lowers in the long run total cost of health care. It provided incentives to reduce the readmittance rate, and we'll certainly be looking at that. It speeds up approvals for both technology and payment models. And it shifts payments to value-based care models rather than simply reimbursing under a fee-for-service basis. And it rewards improved outcomes through increased risk sharing. We will look at all of these in considerable detail as we move forward. It also noted changes in demographics, the effect of COVID, decreases in rates of smoking, increases in the access to prescription medications, in no small part because of the Affordable Care Act. Now for the technical changes, things that decrease costs, slower adoption of technology, and we're certainly seeing, I think, that effect kicking in 2025 as funding models are at risk, as funding for research is certainly being reduced. We see shifts to generic products as earlier items, pharmaceuticals, come off of their protections. They can be replaced by generic products at lower prices. Increasing costs, we see higher costs of pharmaceuticals, particularly for new products. We see breakthrough devices and therapies, and of course, particularly with the notion of recovering investment costs, those tend to have very high initial costs. Things that are, according to the literature, ambiguous in their effect. One is health information technology. I will not agree that in the long run, health information technology will have an ambiguous effect. I believe it will have an improvement. It will decrease cost overall, but perhaps this says at least that it's not to be assumed. Also, predictive analytics and AI, I'd make the same comments. Right now, it may have an ambiguous effect, but I think the impact both on workflow and on healthcare delivery will be substantial. Improvements that are being recognized today. First of all, better fraud detection, which I'll argue is a part of the health IT movement. Enhanced administrative capacities. I put that in quotes because that can be a complex area. One of the ways in which we might have enhanced administrative capacities is to put in pre-authorizations that are based on AI-generated analytics. That may or may not be an improvement. challenges, uncertainty of innovation. Where will innovation take us? Challenges in reimbursement and insurance coverage, particularly in this year 2025, when we see changes that will reduce the number of people who have access to insurance by as many as 15 million. I sometimes hear 17 million people. These things will have an effect on the total cost and the projected cost of Medicare, as they will all insurance. Now, another thing that was in the news that came out July 9th was the MAHA report. This came from the Department of Health and Human Services under Secretary Kennedy. It includes on the cover page this graph, which is significant no matter how you look at it. This correlates on the y-axis, life expectancy, with on the x-axis, the cost of healthcare. I admit this tripped me up a little bit. I had to look at it for a bit. The heading, though, helped me out. Life expectancy and healthcare expenditure per capita by country from 1970 to 2023. So while it covers the periods not organized on the x-axis by year, but rather by cost. So that means we can't slice it and say that the $2,000 amount, for example, represents all of those countries. There's some sliding back and forth as countries might reach those dollar amounts in different years. But it's approximately aligned with the years. And the overall distinction, of course, is that the United States is traditionally near the high end of the cost and at the low end, relatively, amongst high-income countries of life expectancy. And that's true not only of life expectancy, but of other healthcare measures as well. Early childhood, maternal health, things of that sort. Now, I want to pause here and step out of this and look at the report itself for just a moment. This report could be quite a rabbit hole we could go down. And since it's only really a strategy document, this is the MAHA strategy, it's not something that we as practitioners have to react to right now. But it's something we need to be aware of. And so I wanted to look at a couple of high points and talk about one area of it and encourage you, my students, to read this and to look at it closely and be prepared to discuss it as we move forward. According to the title of this report, Make Our Children Healthy Again, the focus should be on children. But beyond this initial set of comments, when you look at the suggestions, most of those suggestions are not limited to children. So under the overall observations related to children, there were 4, focusing on poor diet, chemical exposure, a lack of physical activity and chronic stress, and over-medicalization. I think those are 4 worthy topics. I'm not sure I would have picked them as the top ones, but it's interesting to know that that's where the federal government appears to be coming from as they propose policies in the years and months ahead. Now, as we look inside the report, we see a number of topics under advancing critical research to drive innovation. We should look at all of these. We may talk about these throughout the semester, and I encourage my students to read about them from this article and from this paper and think about them. But I want to call out one in particular. The second one, real-world data platform. They're proposing that we have the NIH will link multiple data sets, such as claims information, electronic health records, and wearables data, into a single integrated data set for researchers studying the causes of and developing treatments for the chronic disease crisis. The RWDP will eliminate redundancies from data collection, linkage, and compute infrastructures, including artificial intelligence, AI, machine learning, and high-throughput analytics, while maintaining rigorous privacy protections and consent protections. It will also dramatically reduce administrative overhead by relying on a unified set of data use and governance agreements. Using just this one, a few things stand out. I don't see a reference in here to the clinical practice of medicine. I see a focus on gathering this information for research, but not for the practice of medicine. Second, the focus of the last 15 years has not only been on digitizing health information, but of integrating that information across organization through health information exchange, particularly the 21st Century Cures Act, which was passed in 2016 and is really still being rolled out as we build a national health information network. So health information exchange begins with the EHR within an organization. It moves from there to a regional, perhaps, health information organization. That in turn merges into a national health information network. How does this RWDP fit or align with what we are already doing? We see cuts in funding, we see pressures in funding. We don't know the alignment. As healthcare IT practitioners, we will be deeply involved in these discussions, if nothing more than to help our clients, our managers, our organizations manage their investments through this difficult time. To me, that's a great goal, but it's ambiguous how it fits with the wonderful work that has already been done. And you can raise similar questions for each of the topics that's raised in this report. So I'm not going to take more time on it now, but I encourage you, my students, and any other viewers to look at this report and give it serious thought. The next thing I want to talk about is something that appeared in the Journal of Medicine and Health Research. And it's a paper by our own colleagues at Indiana University, Indianapolis. Suicide and Substance Use Prevention using Community Health Information, leveraging something called the DHIS2 for Early Detection and Intervention. So first, I want to congratulate our colleagues for doing wonderful work. When we look at the abstract, several things I want to call out, and I should say I assigned this to my students to read this article before this lecture. First, I want to note that our colleagues worked with Randolph County Caring Community Partnership, RCCCP, to conduct the research on which these conclusions were based. RCCCP is a community health services organization that covers 20 counties in Missouri. I have to tell you, I'm somewhat involved with them as well. Dr. Hamid asked me to participate for the very reasons we are here to talk about today. What's the business case? What are the business conclusions we draw from their work? So their executive director, Brian Williams, is working with me and is aware of what we're doing in this lecture. Notice the results. What they did was to analyze survey results from two common surveys, the Drug Abuse Screening Test and the Columbia Suicide Severity Rating Scale. And they asked two questions. They asked, does the DAST, the Drug Abuse Screening Test, suggest or have a correlation with the Suicide Severity Rating Scale? And as the results show, the analysis revealed a weak positive correlation, 0.265. That shows that there's a positive correlation, a slight positive correlation, but not a strong positive correlation. So it doesn't follow that you can predict suicide scores based on addiction scores. But the second part of the analysis, it says here, the logistic regression model achieved 93% accuracy in identifying high-risk individuals with an AUC, area under the curve, of 0.988, confirming excellent predictive capability. That means that when you saw high values in both the DAST and the CSSRS, that had a high correlation with people who attempted suicide in the last year. They then used Power BI, a dashboard tool, to present that information, and they used DHIS2 to integrate information from the two surveys. A moment on what DHIS2 is. If you haven't run into that, and for my students probably have, others probably not. It stands for District Health Information System, number 2. And it was developed in South Africa in the early 90s, I believe, as a health information exchange, a method for keeping health information for patients across broad areas. A district, which is like a state or a region, health information system. And it's since been adopted by many countries, many lower income countries, particularly in Africa. So their thought was, rather than try to integrate these two surveys into the array of existing tools that might be out there, as community health service organizations, which don't have direct access often to electronic health record systems that are in healthcare providers in hospitals or clinics, this was a system they could use on their own to track and present that information using the Power BI dashboards to whatever stakeholder needs that information. So they concluded that there is not a strong predictive association between the DAST addiction scores and the suicide scores of the Columbia Suicide Severity Rating Scale, but that when you saw high scores in both of those, there was a high correlation with people who had attempted suicide in the last year, and that also corresponded with a high correlation for certain other conditions, unemployment, mental illness, things of that sort. So pretty interesting work, and we're going to talk about what that means as we move forward. So the questions I come out with respect to that paper, though, right off the top, what is the problem that the research actually addresses? Who is harmed if we don't address this? And can we quantify the harm? Obviously, the person who dies by suicide is harmed. His or her family are harmed. But we have to ask the question from a business point of view, what's the effect on business stakeholders in the healthcare sector? What are the essential elements of these insights? And here I want to get at the question of what's the important thing. Was it just the surveys and the combination of the surveys, the comparison of the surveys and the results and the analytics? Or does the use of DHIS2 as a database or Power BI as a presentation tool, do those add considerable value, or are they just means to accomplish the analysis of the survey? How can we apply these insights to improve health outcomes? It's one thing to say we saw a correlation between the high results in these two surveys and people who attempted suicide in the past year. It's another thing to say we can predict people who may commit suicide in some future period. And of course, we have to ask, what's the business case for implementing a solution that builds off of the insights from this research? And of critical importance, who would pay for it? How would we know if the solution meets our expectations? These are the questions for health information technologists that we will be exploring not only today, but through the rest of the semester. So that's the introductory lesson 1. For my students, please proceed to lesson 2, and where we'll talk about assignment 1 and discuss the Healthcare Growth Partners mid-year review.